Hi, my name is Greg Taylor. I'm a current clinical lecturer in paediatric dentistry and also post CCST clinical training based at Newcastle University and Newcastle upon Tyne NHS Trust's hospital. Kind of my current role, I suppose, is split academic clinical week, where I spend part of the week focusing on research, sort of my postdoc portfolio, and as well as supervising master's students and other PhD students. And then the latter half of the week, I focus on providing specialist level and then consultant level care for paediatric patients and their dental needs for the northeast of England. So yeah, I graduated with honours from the University of Glasgow in 2012. So kind of followed a traditional pathway of, sort of probation foundation year, or what was called vocational training at that point in Scotland. Did that over a 2-year pathway with some hospital experience and some community dental experience. And at that stage, very much knew that I wanted to be a specialist and go down that sort of specialist training pathway. Had an inkling of an idea of an understanding about clinical academia, and certainly I think wanted to, in the back of my head, at least know that's what I wanted to do. But that way, it wasn't a necessarily formal academic training. Did a couple more years within the hospital services, within the oral maxillofacial unit, and in a pediatric unit. At this point, that's when I started to really build up my interest in academia. Starting off with some very small projects, but got the kind of the appetite when got to present one of those at a kind of national conference, and kind of understood, oh, I really kind of enjoy this, and it kind of fulfilled my sort of interest, shall we say, in learning new knowledge and being able to contribute to that sort of knowledge base. So I was then very fortunate to apply and be appointed as an NIHR academic clinical fellow and specialist trainee in Newcastle in 2016. And I have been here ever since, having completed my sort of pre-CCS training. So in dentistry, we split it up between, so rather than having a 5-year run-through program, we split it 3 and 2. So 3 as a specialist with an exit exam, and then 2 with a consulting exam at the end. So I combined that with my academic training, and was very fortunate that in those sort of 3.5 years, I was able to use a quarter of my time towards academic time. So that was sort of developing my own research, looking at completing a master's in clinical research itself, building together a fellowship idea, and starting to come together about how we were going to kind of work together as part of my supervisor team to get the funding. And then I was very grateful in 2019, within the space of, I think, 2.5 months, I was awarded an NIHR Doctoral Research Fellowship. I passed my Masters of Clinical Research, and then I also passed my Specialist Exit exam, all within sort of, I think, 2.5 months. So I was very fortunate. It was all very much together, but it sort of the ducks aligned, and shall we say. And then it was great because I then was able to take time out of training to do my PhD, which I did full time for 3 years, and completed and submitted that in 2022, scarily almost coming to a year ago. And then had my viva earlier this year, February 23, having passed with minor corrections about a month or two later. And then graduated. So that's where I was up till in July this year. And then as of the 1st of August, I was appointed as an NIHR clinical lecturer in paediatric dentistry. Now, the benefit of doing that is that it allows me to continue with my research, allows me to develop the ideas, start to build up to being a supervisor. So still leading that independent sort of type research, but also giving me the experience of supporting the sort of generation coming behind me. But I also then get half the time to be a clinician. So I still get to practice being a dentist and practice being a specialist, and learn those sort of additional skills required to be able to allow me to sit my consultant exam in a few years' time, with the ultimate next step being that senior lecturer and honorary consultant in paediatric dentistry. my research interests really stemmed from a clinical problem that I saw when I first moved to Newcastle. And I kind of appreciated it a little bit when I was in Glasgow and in the west of Scotland. But it came to light when I saw many of children coming in on a day-to-day basis who had some sort of hole or defect with their first adult tooth. So that usually comes in about age 6.5 to 7. And then ultimately we were making the decision as to when to take these teeth out. And I kind of thought to myself, well, actually, is that the right option? I mean, we're very much just making these, let's just take them out. And is there maybe some considerations we should be thinking about restoring these teeth or putting some fillings in, for example? Or should we be thinking is actually what is the most efficient way? Or is actually this what people value? What do people understand? And I think from that kind of clinical question that I was really interested in understanding sort of stemmed from there where the PhD came from. And I was very fortunate that I work as part of a really strong oral health economics group based here in the university. And these methodologies, which I wasn't aware of at the time and now certainly much more acquainted to, and how they can help answer that question that maybe conventional methodologies would struggle to do so. So I was able to sort of learn those skills and develop those skills. And that's where my interest really lies now, is understanding that problem. So the PhD was looking at the sort of most cost-efficient method, as well as understanding public and adolescent preferences and values for different treatment options. And the kind of maybe slightly beneficial thing was that the outcome was, well, depending on your stance, depends on how you answer that question, how you want to value that question, how you want to decide how to manage. So there's a lot of postdoc work which I'm now moving on to, looking at, well, actually, how do we support decision making with children, particularly with this problem, and how do we support the values of the public in terms of commissioning and sort of delivery of dental care to those across the UK. And that's where my methodology, understanding, and skills with health economics has started to kind of forge its way through, and really thinking there are other ways to help answer these questions. I mean, saying that, that's kind of my focus research, is looking at this particular tooth and the decisions for that. But from those ideas, lots of others areas of research have stemmed, thinking along the sort of similar line, but that sort of shared decision making, that pathways type research, that economic evaluations and sort of economic valuation and preference type studies, but for other aspects of pediatric oral health. And it's such a nice area to work in, because actually we societally and historically have always decided what's done for children. And we very rarely involve children and young people in healthcare decision making. That is certainly changing. And I think that's where I'm really passionate to understand, how do we better that for the patients? How do I make sure that my 9-year-old coming in gets to say in what happens to his treatment? And how do I know that we're supporting these patients and understanding what values and getting their input into that process? I think for a long while we were a very research active department. I think as a school and a university, we're a very research active school. But it's only probably recently that I would say the Paediatric Oral Health Group has really started to, the Paediatric Department, sorry, has really started to kind of see the benefit of being involved in research activities. And when you see the patients coming in and the interest that patients get from, oh, I could potentially be part of a study, and oh, this is interesting, I think they get a real sense of being part of something that's really revolutionary and really supporting the next generation of their peers. I suppose they see it as a way that they can advocate for their rights and also advocate for their future brothers, sisters, or whoever that may be. I also think as well, from being in a research active department, I think the patients really can see the benefit of, well, actually, these guys are making changes and are actually starting to understand what's happening. And certainly patients I've recruited for my PhD and subsequent studies, when you actually get to chat to them, and I get a lot of my early prior work of any project is doing some qualitative interviews and focus groups with these young people. They really want their voices to be heard. They really want their understanding. And I think it then makes it a lot nicer when you know that they're coming back to have the treatment, that they've played a little bit of a part of that journey. And certainly I think as well, their parents are sort of very complimentary as well, that they can realize that we're making a concerted effort to not just go along with what we've already done, but to try and buck the trend and start to make things better for their child ultimately, but also more altruistically for the wider population. Probably one of the challenges of being a clinical academic or following a clinical academic pathway is the length that it takes. And certainly, I think going into any sort of training pathway that is a clinical academic post, you appreciate that that's going to be the case. Certainly, if you were to follow a pure clinical training pathway, you would often finish that conventionally 5.5 years. Whereas if you follow a clinical academic pathway, often this can be a lot longer, sometimes in my case up to 12 years. And that can be really frustrating in many regards, considering when you maybe aren't rewarded or remunerated the same as what you would have been had you just followed an NHS pathway and got there quicker. It also, I think, is a bit frustrating in terms of the time element, as in you've got to put a lot longer in. So yes, your clinical training might take 5 years, but actually when you have to do it part-time, you feel as if, well, I'm probably ready to sit my exam, but I've just not done enough time yet to do that. Or I'm not enough time to be eligible to exit. And then the other frustration is that there's some aspects of your academic life that probably are transferable in their skills to your clinical training. And that's not for me here to decide. That's for people higher up in sort of specialty advisory committees and boards to make a decision of whether that's relevant or not. But I certainly think going into any clinical academic pathway, there has to be that understanding that you will be there longer than your colleagues who would be starting at the same time on an NHS pathway. And I think as long as you accept that early on, it shouldn't really affect you, because I very much sort of succumb to that idea from a very early stage. But I suspect if you don't consider that, it could be a real problem and challenge when you start to see your potentially junior colleagues to you suddenly becoming more senior colleagues, or even your consultant bosses and trainers, and that can be a quite challenging dynamic for some. But unfortunately, it's the realistic nature of following that slightly longer pathway. But as we mentioned, with the potential benefits of being a clinical academic, it is about weighing up that balance. Looking back, certainly resilience is probably the one that I think as a clinical academic. A lot of times, in particular thinking back, by the nature of doing medical and dental degree, and a dentist degree in my case, getting all the training jobs that you want and sort of succeeding in postgraduate certificates, you tend to think that yes, this is relatively simple and straightforward. And it's not until you get that first kind of knockback, whether that be a grant rejection or whether that be a paper being rejected, and you think, oh God, all hell is going to, this is just, it's a waste of time. Why am I doing this? I think if I was to look back at myself and say, everything will come right in the end. Things in life are always meant to be for a reason, and having that real resilience of going, well, do you know what? It is a tough gig being a clinical academic, but if you're resilient and you continue to be motivated, enthusiastic, you will get the rewards, and you will reap the benefits of your labor you've put into it. And that for me is the fascinating thing, and the thing I love most about being a clinical academic is that I get to see those aspects. I get to kind of have those knocks, but then kick them back and say, well, do you know, let's see what I can do, and let's understand what, if I can do something better, or do you know what I mean? I can maybe a little bit of internal sort of pressure on myself. Well, no, I can better what they've said. So yeah, certainly being resilient and being a bit more resilient and understanding that things do go wrong and things certainly will not work first time. I think I can remember on several occasions I wanted to throw my laptop out the window during my PhD because things weren't going great and it was hard and stressful. But in the end, the result was there and I got what I wanted to. So just being that little bit more resilient probably would have helped, but benefit of hindsight is a wonderful thing. the joy that I get out of understanding new things, that I get to be involved in the sort of the forward trajectory of the oral health research landscape within the UK and internationally. We're a relatively niche and relatively small group, but have a massive part to play, given that we know that dental health is one of the most prominent reasons across the UK and the world as to why children access general anaesthetics or healthcare admissions or treatment. So it's a massive problem. As a clinical academic, I get the best of both worlds. I get to support that research, do the research, answer the questions that need to be asked. I get to support the generation coming behind. I get to teach the undergraduates. I get to enthuse and try and motivate these people to make the best for their careers, but also to ensure that they provide care for pediatric patients as I would myself and have that same passion and love. But also I get the other side. I get the clinical side of things. I still get to be a practicing dentist. I still get to go to theatre. I still get to see my patients and see the joy that you get from the satisfaction of seeing that patient manage a treatment that they can't get, or have that anterior tooth which has been destroyed from a cricket ball or a hockey stick or something, and re-bringing their smile back. These sort of satisfaction and gratifications are why I originally wanted to be a dentist. So for me, it's having that balance of both clinical and academic activities that just make my job totally worthwhile. And I never genuinely, it's very cliche to say, have a day where I kind of think, oh God, I've got this today. I love every day that I come into work, because my week is so different and so varied every week. And that is the benefit of being a clinical academic. You get to be involved in many things, but you get the variety that you wouldn't necessarily get if you were a pure clinician or a pure academic. You get the best of both worlds.